Kannan Venugopal. He's the head of department at Royal Perth Hospital. He's the most keen and enthusiastic gastroenterologist in town. He loves gastroenterology, would be fair to say. He is a wealth of knowledge. He's trained here in Perth, started off as an RMO, then went through the whole training system, and then went on, specialised in inflammatory bowel disease, which he did at Fremantle Hospital at the time, and then overseas to Edinburgh for a period prior to coming back to Perth and being appointed at the Royal Perth Hospital. So he's going to talk to us about diarrhoea. When people asked me what I was doing this evening, I said I'm going to a dinner talk on hepatitis and diarrhoea. So it's good to see that we've got so many people here. Thanks,
Thanks, Nick. Thanks for the very kind introduction. It's a bit rude to talk about diarrhea just when you're about to have dinner. But sorry, it's just placed that way. Look, thank you for coming, and thank you for giving up your evening for this, and hopefully we'll make it worth your while. Daniel, my wife's a GP, so I showed her my talk, and hopefully this is tailored to what you would like. I'm not trying to teach you everything about diarrhea. Obviously, I can't, but we'll just go through a few. What I've tried to do is to do an outline and an overview, and then we'll talk about a few cases that I have seen in the last year or so. And like with Sam's talk, please feel free to interrupt and ask questions. I hope you can hear me at the back as well, reasonably well. Okay, so when I was doing this talk, the first thing that struck me was how much pediatric diarrhea is out there. So please just avoid the pediatric questions, because I wouldn't know what to say. So this is an approach to diarrhea in adults in general practice. So this is the talk outline. It's acute versus chronic diarrhea. How do you approach chronic diarrhea? What relevant investigations before you consider referral, and when to refer, including what red flag symptoms you look for, and a few clinical scenarios, and how I have perhaps learned from my own mistakes, and we'll talk about that in more detail. So acute versus chronic diarrhea. Acute is typically something which lasts for less than 14 days. 3 or more episodes of loose stools, Bristol 5 to 7. I'll show you a picture in a minute. It's most commonly viral. That is why your uptake, or if you do a stool culture, which is really not recommended, your pickup rate is so low. 60 to 70% no cause is found, and empirical antibiotics is not recommended really, because it should self-resolve unless you suspect Clostridium difficile or some particular conditions that we will talk about. We'll get this out of the way. You can't go to a diarrhea talk without seeing this, and it has come before dinner, so just look. So 5 to 7, Bristol stool chart, 5 to 7 is generally diarrhea. Okay, what causes this? Most commonly, like I said, viral, adenovirus and norovirus. Uncommonly bacterial, Salmonella, Campylobacter, Shigella, E. coli, and Clostridium difficile, especially in the setting of recent antibiotic therapy. Rarely protozoal, Giardia, Cryptosporidia, Entomoeba histolytica, Cyclospora. And stool cultures, like I said, is positively in a very small proportion of patients, because these usually self-resolve. So while it is self-limiting, what to look out for? So in some people, there can be profuse dehydration, and some people can, especially the elderly, they can go into renal failure. So, if you're checking bloods and you think that there is significant dehydration, check the USNEs. If it's bloody diarrhea, obviously you need to be worried about infected causes as well, and Shigella is a possibility. If you look at the spiel that comes under the stool culture report, it says that Shigella you probably don't need to treat, but it's recommended that you can perhaps treat Shigella for 2 reasons. 1, you shorten the duration of the illness, and number 2, it's a fecal-oral transmission. You reduce transmission to household contacts, so perhaps treat. If you're recent use of antibiotics, then always worry about C. diff, particularly in the older or people who are on immunosuppressive medications, and in elderly over 70 years of age or immunocompromised patients, you would have a low threshold to treat. What historical clues do you look for? Symptoms within 6 hours of ingestion. I ate something, within a few hours you're having diarrhea, usually Bacillus cereus or Staph aureus. If it's more than 16 hours, it's viral or bacterial. It doesn't really differentiate it. And I think I said this already, this is the third time, limited value in testing for testing stool MCS. I had quite a humbling moment a few weeks ago when a patient asked me, how do I do this? I said, an adult patient. So yeah, look, it's a very pertinent question. And I said, oh, look, this is how you do it. So asking them to use a wide mouth container, maybe an empty yogurt container, is perhaps okay, because the collection kit comes with something that you can transfer it into the container. And there is no sticker on the collection container. Ask them to write their name and date of birth on it before you collect. So that's very vital. So it might not be the best to write it on, anything to be written on. So if there is a sticker, fine. Otherwise, write the names beforehand. So when to treat? So traveler's diarrhea with significant symptoms. This is all acute diarrhea. And there are symptoms more than 10 days of significant symptoms. If your patient is immunocompromised, I have a low threshold to treat. Empirical treatment with norfloxacin 400 milligrams twice a day for 5 days, or azithromycin for 3 days is perhaps not unreasonable. Look, we don't see this at all, and this is all your realm. This is, stops with you. We don't get to see this because you manage this all very well. So we actually are not involved at this stage in almost no patient with acute diarrhea. So there you go. This is almost entirely managed at a GP practice. So, but coming to chronic diarrhea, that is a fairly exhaustive list, and it's not my intention to take you through this entire list. So it goes from common, infrequent, and rare causes, and Zollinger-Ellison syndrome, as somebody asked, would be a very rare cause. So common causes the commonest thing would be IBS-related diarrhea. There could be bile acid diarrhea, diet-related, celiac disease, 2 to 3% prevalence in Australia. Very commonly, drugs can cause diarrhea, antibiotics, and ulcerative colitis or inflammatory bowel disease, Crohn's disease can cause diarrhea, and a variety of things, small bowel lymphomas, radiation enteropathy, uncontrolled diabetes, where autonomic neuropathy is a predominant feature, where you can have diarrhea or vomiting, or both. So, and it goes from rare to more rare causes, which we probably don't need to go there. So chronic diarrhea is defined as something that's been present for more than 4 weeks, more than 3 bowel actions a day, and somebody's actually done this test to measure it and say it's more than 200 grams per day. There you go. But it has to be watery. So diarrhea, it's either increased frequency or change in consistency. And there are various subtypes. There is secretory, osmotic, inflammatory, or fatty. But the American College of Gastroenterology, in its wisdom in 2017, revised their guidelines and made it inflammatory, fatty, and watery. So I can't remember the last time I did a stool osmotic gap, but you can still do it. And the CliniPath offers that test. So stool osmotic gap, particularly, this is useful if you think that the patient is a laxative abuser, for example. 290 minus 2 times stool sodium and stool potassium, more than 125. It's pretty damning for osmotic diarrhea. And it's a very good clue that the patient is actually consuming some osmotic substance, maybe not, unwittingly. So osmotic diarrhea is due to an ingested osmotic substance or substances, and typically laxatives, and it improves while fasting.
Can you elaborate on what they may be ingesting unknowingly? What sort of?
Yes, sorbitol, macrogol. It could just be sugary substances. Something that they might not actually even know that it is osmotic. So licorice, for example, heavy consumption can cause this. Yeah, look. So osmotic diarrhea is usually something that you're ingesting, and but therefore, if you're not ingesting, if you're fasting, it typically improves significantly. Whereas secretory diarrhea has a wide variety of causes: carcinoid tumors, lymphocytic colitis, microscopic colitis, ZES, Zollinger-Ellison syndrome, VIPoma, which is another one of these neuroendocrine tumors, intestinal lymphomas, celiac disease, collagenous colitis, and hypothyroidism. They all cause secretory diarrhea. Fatty diarrhea is usually due to malabsorption and almost always due to pancreatic disease, bacterial overgrowth, or celiac disease. So greasy, floating stools which are difficult to flush, which is the classical description of a malabsorptive diarrhea. And almost always there is attendant weight loss. It's usually a patient who comes and tells you that they can't keep anything down, they find it very difficult to flush their stools, they're losing weight, they are emaciated. So that's the typical history, with a significant alcohol history perhaps. So if you suspect pancreatic disease or you suspect chronic pancreatitis as a cause of this person's diarrhea, get a CT done. So because we've gone beyond doing 24-hour fecal fat estimation for fat malabsorption. If there is pancreatic disease, do a CT, which almost always will show pancreatic calcification or atrophy, and so that is something that would be seen in chronic pancreatitis.
Should I ask for fecal elastase before CT?
Yes, no, I'm coming to that. You can definitely ask for fecal elastase. So it is actually okay.
Quick question.
Thank you. Should you ask for fecal elastase before CT? I think it's a very good question. So yes, if you suspect pancreatic malabsorption or malabsorption secondary to pancreatic disease, please ask for fecal elastase as well. I think it is. I'm coming to it in a few slides, but yes, along with the CT. But use it as a complementary test, rather than an exclusive one. So once you establish pancreatic insufficiency by fecal elastase and or CT showing pancreatic atrophy and calcification, you can trial pancreatic enzymes. But I think we're talking a bit more in a bit. Inflammatory diarrhea is the other important cause. Australia has one of the highest rates of inflammatory bowel disease in the world, ulcerative colitis and Crohn's disease per se. So in these patients, there is inflammation and ulceration which compromises the mucosal barrier, and mucus, protein, and blood is released into the lumen. Typically, the history is that of bloody diarrhea. So the causes of inflammatory diarrhea include ulcerative colitis, Crohn's disease, and very rarely chronic infections, which we don't see here very commonly. TB, chronic intestinal TB is a cause. Amoebiasis, rare, and Clostridium difficile colitis if it's prolonged. So they can all cause inflammatory diarrhea, but for most purposes, for inflammatory diarrhea, the most common causes would be ulcerative colitis and Crohn's in Australia. So the history is that of bloody diarrhea, tenesmus, cramping, fevers, and weight loss, and a family history of IBD. When somebody tells you that, oh, there's blood in my stool, a very good question to ask would be, is there urgency? Usually that is a very early symptom of ulcerative colitis, and I'll tell you why. Ulcerative colitis starts in the rectum, and if the rectum is inflamed, you're unable to hold it in because the rectum is your reservoir. So an inflamed rectum is unable to hold on to stool. So if somebody says that I've got blood in the stool and I get no notice, if there is urgency, I think that's a bit of an alarm, a red flag. So other red flags. So if there is ongoing fevers, blood loss, unexplained weight loss, abdominal pain, especially nocturnal. I go to sleep, I wake up in the middle of the night with pain. That's a red flag. Nocturnal diarrheal episodes. Like, do you have to go in the night? Oh yeah, I go to do a wee. No, not that. If you're waking up in the middle of the night and you're having nocturnal diarrheal episodes along with weight loss or blood in the stool, red flag. So they have to be referred on ideally quickly. What in history? History of intestinal surgery is important. Rarely radiation. I mean, not a lot of people have intestinal radiation. Diabetes, alcohol history, excessive alcohol can cause malabsorption in itself. Check diet. Check what are they actually having. Are they having a lot of FODMAPs, which can cause diarrhea as well? Diet sweeteners, which can cause osmotic diarrhea. Travel history, a family history of IBD. But having said that, first degree relative with family history is only seen in about 15 to 18%. So over-the-counter medications, laxatives, and an important cause is magnesium supplements. Magnesium is cathartic, and if they've just started taking, Biomag or Magmin twice a day, and that could just be it causing the diarrhea. So drug cause is very important. What investigations can you do? Stool MCS, perhaps at least 2 samples, because if you do 1 sample and there is a bug, there's a bug and you do 1 sample, your chance of picking it up is about 90%, but 2 samples, your positivity rate increases to about 97 to 98%. Perhaps 2 separate stool samples is good. So if the stool sample is clear as in there are no bugs, but if there are leukocytes, that suggests that it could be inflammatory. So, which should alert you to the possibility of this being ulcerative colitis, because ulcerative colitis typically negative stool cultures, but presence of leukocytes. So, if there are leukocytes in the stool, then it is a bit of a worry. Calprotectin is a non-invasive test. I'll talk a bit more about it in a minute. Fecal elastase, very good point you made, to look for pancreatic insufficiency, and just do the bloods, including just the common things, thyroid function, checking albumin and INR to look for malabsorptive processes, celiac serology, CRP to check for inflammation, and B12 and folate for a rare cause, which is small intestinal bacterial overgrowth. We do see it in patients who've had abdominal radiation, or some people who have had intestinal surgery. So vitamin B12 and folate would be useful to do as well. So that's the general set of investigations that you do. Fecal elastase is covered on Medicare, I think, but fecal calprotectin is not covered. So what is fecal calprotectin? Fecal calprotectin is a neutrophilic protein released by colonic epithelial cells in inflammatory states. It's increased more than 10 times in inflammatory bowel disease. Reasonably reliably, it differentiates IBD, which is inflammatory bowel disease, from IBS, which is irritable bowel syndrome. So organic disease versus irritable bowel syndrome is, you can reasonably well differentiate with the fecal calprotectin in patients under 50 years of age. I say 50 years of age because that's kind of the cutoff. Anyone who's over 50 years of age with the normal fecal calprotectin and prolonged symptoms, you're probably not completely comfortable sitting on them. But under 50 years of age, a normal fecal calprotectin virtually excludes inflammatory bowel disease as a cause. And you can use that as a fork in the road. You're coming in with diarrhea, some nocturnal symptoms or intermittent nocturnal symptoms, but a completely normal fecal calprotectin argues against this being an inflammatory bowel disease. The positive predictive value is very low. If the fecal calprotectin is elevated, so it's super sensitive. So if there is the slightest bit of inflammation, it'll be up. But if it is up, it doesn't tell us anything. If it is up, it could be an infection, it could be anti-inflammatory drugs, it could be ulcerative colitis. So if it's up, it probably needs investigation, but it doesn't tell us the cause per se. And I'm a fan of CT. It's saved me a lot of trouble a lot of times. Obviously in a young person under the age of 30, you don't want to use a CT, but in an older person with significant GI symptoms, a CT is a very valuable investigation. You can look for colitis, enteritis, diverticulitis, pancreatic pathology, and this is what I tell my patients too. You've had an endoscopy, a colonoscopy, and a CT scan of your abdomen. You're fine. You're really fine. So it actually is quite reassuring. So that is generally about what you do when you're faced with diarrhea, chronic diarrhea, investigations, and including bloods, stool tests, and imaging. And I'm very happy to take any questions, or otherwise we'll just go to a few clinical scenarios. I've got about 4. Yes.
What's the difference, the age difference? You said under 50, that fecal calprotectin negative, that's fine. Why not all?
Okay, I will repeat the question. I remember that actually. So why fecal calprotectin is good under 50? So it's slightly arbitrary. This is not arbitrary as in arbitrary from me. This is what the societal guidelines are. So the thinking is that significant organic disease is a bit unlikely in someone under the age of 50. I'll qualify that. So a fecal calprotectin normal usually excludes inflammatory bowel disease in patients under the age of 50. But in somebody who's over the age of 50, your normal fecal calprotectin doesn't necessarily exclude other problems. Inflammatory bowel disease is perhaps still unlikely, but other problems could include, say, colonic neoplastic lesions, so which a normal fecal calprotectin does not exclude, which is why that 50. It is a bit arbitrary, and it actually might be dropped to 45 in the next few years, because in America they're actually thinking very strongly of dropping it to 45. Yes? Is there any role for multiplex test? Yes. Look, PCR test, which is a fecal multiplex test, is super sensitive again. It's worthwhile doing. Stool culture or fecal multiplex test should be fine. But 2 samples ideally. Yeah.
Is it
Love that question. Okay, so blastocystis is sorry. Yeah. Thank you. So fecal PCR, blastocystis positive. What to do? So it's actually fairly common to see blastocystis positivity. So the guidelines differ. If you read CDC, which is Center for Disease Control, their website, they says not to treat. Okay, but Australian guidelines say in the absence of something else with which you can describe their symptoms, to best treat. So yes, I mean, I think metronidazole is fine. A 7-day course should clear it off, but it's unlikely that the blastocystis is causing their symptom. I think, if there's a bit of small intestinal bacterial overgrowth, it'll treat that as well. Patient feels good. So in America, they wouldn't treat, and the recommendation is very clear. CDC guidelines said not to treat, but in Australia, I think it's reasonable to treat. And the ETG, which is the therapeutic guidelines in Australia, would say to treat. Yes?
There was a mention of caffeine and sweetness in your history taking. Is that to do with microbiome, and does it include stevia? And what's wrong with coffee?
There is nothing wrong with coffee. There's nothing wrong with about caffeine. The question is about caffeine and microbiota. What's a stevia?
Artificial sweetness.
Oh yeah. So excessive use of artificial sweetness can cause osmotic diarrhea. How do you define excessive use? I did look it up. I don't think it is actually said anywhere. And excessive coffee consumption, particularly if you're having it with a little bit of milk. I mean, lactose again can contribute to intestinal discomfort, diarrhea. I mean, this is in the list of things, but it is about teasing it out as to how much they're actually using.
Does it affect our microbiome?
It probably does. Does it affect the microbiome? Yes, it probably does. But look, I think it's beyond the purview of this talk to discuss microbiome. It is perhaps as a talk in itself, which I can do next time. Okay, the clinical scenarios. This is the first one. In UEG, back in the day when we actually could go to meetings and listen to people talk, there's this meeting in Europe. It's called the UEG, or the United European Gastro Meeting. It's a very popular meeting, and one of the most popular sessions at that meeting is mistakes in whatever, colorectal cancer, pancreatic disease, and it's a packed session because everybody wants to learn from everybody else's mistakes. So look, this is one of my early cases. It's like a memorable case for me. First year as a consultant, and perhaps I learned most in my first 2 years as a consultant than in my training. So look, there it goes. So the 92-year-old was referred to me with diarrhea, which had been present for about 3 or 4 months. She said it was watery, small volume, 5 or 6 episodes a day, Bristol 6, 7, and she had urgency. She was unable to go shopping. It was obviously socially disconcerting. She had to wear pads, which was completely new for her. She had a past medical history of colonic cancer and had a right hemicolectomy in 2004, had hypertension, osteoarthritis, hypothyroidism, or GERD, and she was on antihypertensives, some multivitamins, no magnesium. I did check that, thyroxine and Pariet. And these were her investigations. So the full blood picture USNEs, LFTs and CRP, thyroid functions were normal. Her fecal elastase was normal. Her fecal calprotectin was normal. Her gastroscopy and duodenal biopsies were normal in 2018. And I was looking for a reason not to put a scope in a 92-year-old. So there was obviously no need to repeat. Her colonoscopy, she'd been having regular scopes. It wasn't through me, was normal in 2016. And her vitamin B12 and folate were normal. She was treated empirically with loperamide for 4 weeks, and I said, oh, look, come back in 4 weeks and we'll see you. When she came back, she was no better, had ongoing symptoms, hard to manage at home with symptoms, and was really struggling, and she really wanted to be admitted. And because of all the other problems, one of the geriatricians took her on and did a CT of her abdomen and pelvis, which was also normal. Look, does anybody want to have a go as to what clinched it? Anyone? Yes, Anne.
I'd ask more about the medication she's on.
Yeah, she.
Thyroxine and Pariet.
Yeah, these were all medications long term, and the symptoms were fairly new. Anyone else? The investigations. She had an abdominal X-ray which showed that there was significant fecal loading. So when Millie Wong, who was a geriatrician, you have to give credit where it is due. Millie said, Karen, I just did an abdominal X-ray and it was full of crap, and I just cleaned it out and she was fine. I said, thanks, Millie. Thanks very much. So it was overflow diarrhea due to fecal loading. And the management is just bowel cleanse, brief hospital stay, some pelvic physiotherapy, completely well on follow-up. I said, very humbling. So thank you. Thanks very much. So now everyone who comes to me, anyone who's older gets an abdominal X-ray first. Okay, so I mean, look, we are all living and learning as we go. But on the contrary, this is a good case for me personally anyway. This is about 6 months ago. It was my on-call weekend. I had a phone call from the Armadale ICU consultant. I'm like, oh my God, what does he want now? Who's he transferring now? So 66-year-old patient was in ICU post extended right hemicolectomy for a transverse colonic cancer. And she had a stoma and had high ileostomy output, basically resulting in renal failure. So the patient was on CVVHD because of the high stomal output. And regardless of what they were doing, they couldn't get the stomal output under control. And was referred, and he's ringing me for management advice. And the patient is now on total parenteral nutrition, or almost total parenteral nutrition. So other medical problems, hypertension, rheumatoid arthritis, migraine, medications, so olmesartan 4 milligrams once a day, leflunomide, Pariet, codeine twice a day, which was started only for the diarrhea or the high ileostomy output. Had some investigations, full blood picture, hemoglobin 108, white cell count of 5.5, platelet count of 227. USNE showed that sodium was okay, potassium was okay, creatinine was about 300. Like I said, the patient was on dialysis. And the stool MCS, they had done the ileostomy output a few times, and it was negative. They had done a celiac serology, which was negative. So I still remember this because I was on call, and I said, look, I'll look it up as we speak. And I was looking up on iSoft the results as well as he was talking to me. So when patients have high ileostomy output, they go on high-dose PPI to reduce the hypersecretion-induced diarrhea, as Sam was saying. She was on loperamide 4 tablets twice a day, which is basically maximal dose. On codeine 60 milligrams BD, again, supramaximal dose. She almost completely had the colon intact. She'd had a right hemicolectomy, which leaves at least 2/3 back. Mary, is that right? Mary is a colorectal surgeon, yeah. And she was planned for reversal. And if you have a colon back in place, because a lot of reabsorption happens in the colon, you're generally okay once you're reversed, but they were not sure when that was planned. And as I was talking to him, I said, look, we'll look at the index gastroscopy and colonoscopy. So I looked it up, and it was actually done for iron deficiency anemia because the endoscopy was normal, and the colonoscopy at that time showed a transverse colonic mass, which is why she'd had the extended right hemicolectomy and was now in ICU. And I told him that I know what the answer is, because the biopsies from the duodenum at the time of the endoscopy showed total villus atrophy, and her celiac serology was negative. And as Anton was walking to the desk, I said, it's the olmesartan. She's on olmesartan, which I did not know. And the diagnosis is olmesartan-induced enteropathy. So it can cause an absolute celiac disease-like picture with total villus atrophy, and the patient had a short course of steroid, complete resolution of symptoms, the USNE is normalized, she was off CVVHD, olmesartan was ceased, substituted for something else, and she's had an ileostomy reversal, and she's completely well. So olmesartan-induced enteropathy was first described in 2002, and first used in 2002. The olmesartan-induced enteropathy was only first described 8 years ago. There is a long duration between introduction of the medication and the onset of enteropathy, so that the lack of temporal association means that it's kind of lost on the practitioner that it could be olmesartan. So there's no temporal association between the commencement of the drug and the symptoms. So it's therefore overlooked as a cause. It causes watery diarrhea. It is a a celiac disease mimic with a negative celiac serology. So if you get somebody with total villus atrophy and negative celiac serology, then olmesartan could very well be the cause. It's really only limited to olmesartan because there have been 248 cases described in literature. 94% is with olmesartan, a little bit with telmisartan, and a little bit with irbesartan, which was only published last year. So not a lot of cases there, but diarrhea in a patient who's on olmesartan, just think about it as a possibility. Third case, very recently again, 47-year-old lady. She's an accountant, had no medical problems, had traveled with her family to Indonesia in January this year. She had gastro whilst on holiday and symptoms persisted. And she was treated at a local clinic with some antibiotics. She didn't remember if a stool MCS was done. And then she came back, symptoms on return home. This was February 2020. Stools were done, and at that time, Giardia was positive. She was treated with metronidazole for 7 days. She was well for a month, and then worsening symptoms again. Started going to the toilet, opening her bowels 5 to 6 times a day. Weight loss, intermittent bloody stools, and a repeat stool MCS was done with fecal multiplex PCR that was negative. Her family, she had a family history of IBD. Her mom had UC, and I think that's why whosoever referred her to me, thinking that this could be IBD, very well so. So if you look at differential diagnosis of traveler's diarrhea, it could be viral, Giardia, cryptosporia, entamoeba histolytica, C. diff, or E. coli, but a large majority of this is excluded by doing the fecal PCR, multiplex, and the stool MCS. Her full blood picture was normal, USNEs were normal, LFTs showed slightly low albumin, otherwise was normal. Any other tests? Anybody? Just shout out. So fecal calprotectin was done. It was significantly elevated. Fecal calprotectin was over 1,000. Fecal elastase was done. That was normal. Thyroid function tests were done, which was normal. So like I said, the fecal calprotectin being high, it does not tell me what the cause is. It just says that it's an inflammatory diarrhea. Celiac serology was done, which was normal. She then obviously, came to a gastroenterologist with 6 months history of diarrhea. She gets an endoscopy and a colonoscopy. Her gastroscopy was normal, including duodenal biopsies. Colonoscopy, I've got some pictures there, and that's the rectum. Sorry, that's a sigmoid colon. That's a rectum, which is near normal. What you see in white are all ulcers. And that was the right colon. So she had what we call as what I thought, or what looked like skip pattern ulceration, deep ulcers in the right colon and transverse colon with intervening areas of normal mucosa. And it looked very much like, anyone want to have a go? Crohn's disease, because family had history of ulcerative colitis as well. So again, it was like I go to her after this. I know the stool cultures were negative. And I go to say, and I talk to her and I say, oh, look, I think you've got Crohn's disease. I've done biopsies, and we'll wait and see what it shows. But you're looking at a lifetime of immunosuppression. Getting a bit too far ahead of myself. And a couple of days later, Priyanthi Kumar Singh, who's a fantastic pathologist, she rings me and says, Kannan, it's not Crohn's disease. Anybody want to have a go what this is? Because there is the arrow sign. So those are red blood cells with ingested amoeba. So it was invasive amoebiasis with colitis. And what you saw there, oops, how do I go back? Oh, you won't go back. That's okay. Those are flask-shaped ulcers, which is typically described in amoebic colitis. So it is invasive amoebiasis with colitis. She was treated with a 14-day course of metronidazole. She did have, if you remember the history, she did have some metronidazole at the start. But what she did not have was, she was treated for Giardia, of course. If you do not get a luminal amoebicides to clear out your cyst, then you can reinfect. And so that's what happened. And I treated her with paramomycin. Again, it's a SAS application drug for 7 days. And then a CT abdomen was done because she had long history of symptoms. Rarely you can see it in the liver, and that was also done, and she's completely well after the 21-day course of antibiotics. So 50 million infections and 100,000 deaths worldwide. Developing countries are most affected. We don't see it very commonly here. You get your infection by ingestion of food or water containing mature cysts, And excistation of these cysts happens in the intestine, and the trophocytes are released, which penetrates the intestinal mucosa and can migrate through the enterohepatic circulation to the liver, cause liver seeding, and cause liver abscesses. Majority of the infections are asymptomatic or minimally symptomatic. And then stool microscopy actually identified them. I think she had one which was negative, and the one that I did at the time when I actually did a scope, I did another sample that actually showed the PCR positive for Entamoeba histolytica. Serology is useful. It is rising titers in intestinal disease. Fecal PCR, like I mentioned. Colonoscopy and biopsies is obviously gold standard. And treatment with metronidazole followed by paramomycin to eliminate the luminal cysts. How am I going for time, Nick? Am I okay? Okay, shall we do one more or? Yeah. So that was the diagnosis. So invasive amoebiasis with amoebic colitis, and much better diagnosis than Crohn's disease. And she was very, very happy. As a last case, as a 52-year-old school teacher was referred for evaluation of a 6-month history of diarrhea, quite disabling symptoms, watery stools about 5 or 6 times a day, nocturnal symptoms, socially disconcerting, having to leave this class, not good, not ideal, had urgency, no weight loss. She had anxiety, hypothyroidism, hypertension as previous history, some cesarean section and tubal ligation, and had a cholecystectomy about 23 years prior. She was a non-smoker, drank no alcohol, and there were no over-the-counter medications. That was her medication list, and I think when she was referred to me, the fecal calprotectin was normal, thyroid function was normal, fecal elastase was normal. Endoscopy and colonoscopy, normal again, normal duodenal and colonic biopsies, and like I said, I quite like the CT, so she had a normal CT abdomen too. Anyone want to have a go? We know enough to know that this is this condition. Anyone? Just have. It's post-cholecystectomy of bile acid diarrhea. Again, patients go from person to person, long quiescent period between the cholecystectomy and the symptoms, so which is why it is overlooked as a cause. Incidence is about 9 to 10%. It's because of dysregulation of bile acids entering the intestinal lumen. Bile acids, if it were cheaper, we would use it as a cathartic agent. So they can have symptoms as early as first month after the cholecystectomy, but can be delayed up to 30 years after the cholecystectomy. And it's universally responsive to bile acid binding, cholestyramine, which is difficult to obtain at this time in Perth or anywhere in Australia because the supply chains have dried up. But if some of the chemists can actually compound it for patients, and there are ones in Mount Lawley, Leederville, and Fremantle who can compound it. And so, but bile acid diarrhea is universally responsive to questran or bile acid binders. So that was her diagnosis, and she was very, very happy, completely well. So take-home messages: it's a common medical problem, second only to reflux. So reflux in the general practice GI presentations, most common. Second most common is diarrhea. The importance of history, surgeries, medication, alcohol intake. So focused evaluation and directed testing is what's recommended. IBS-D, which is diarrhea predominant IBS, is still the most common cause of the diarrhea in the community. And although we looked at this esoteric or rare cases, common things are more common. Involve your friendly neighborhood gastroenterologist, especially if you're worried. There could be diarrhea here, pain there. Share the pain. So we're very happy to be involved. And watch out for the red flags. And look, that's from the British guidelines from last year. Look, I'm very happy to email this to anyone who is interested. But we've basically covered all of that now in this talk. Look, thank you very much for your attention. Thanks for coming. And please let us know if what you'd like to change the next time we do this. We're very, very happy to take any feedback. That's my personal